Good afternoon and welcome to this EAS webinar on non-alcoholic fatty liver disease, NAFLD. I am Professor Olof Wiklund from the University of Gothenburg in Sweden. This is the first in a series of webinars arranged by EAS and the EAS web learning platform, the EAS Academy. Non-alcoholic fatty liver disease is a common condition and it is projected to become the first cause of transplantation in Europe and in the United States. The disease comprises a spectrum of conditions, from steatosis to steatohepatitis, fibrosis, and ultimately to cirrhosis and cancer. Interestingly, NAFLD is also strongly coexisting with dyslipidemia, and individuals with NAFLD often present with cardiovascular disease. In this webinar, the speakers will report on the current knowledge on NAFLD, focusing on the cardiovascular risk aspect. The presentations are given by three frontline researchers in the field. That is Professor Christopher Byrne from the United Kingdom, Professor Stefano Romeo from the University of Gothenburg, and Professor Luca Valenti from the University of Milan. At the end of the presentations, the speakers will be present online to answer questions and discuss. Please, let's start with Professor Christopher Byrne.
Good afternoon, everyone. My name is Chris Byrne, and I'm Professor of Endocrinology and Metabolism. These are my declaration of interests. The content of my lecture over the course of the next 15 minutes is shown on this slide. I'm going to begin by describing to you the natural history of Nafl and show you it represents a spectrum of liver diseases. I'll describe to you the concept of Nafl as a multi-system disease with effects beyond the liver, and I'll discuss with you how Nafl increases risk of extrahepatic complications such as cardiovascular disease, type 2 diabetes, and chronic kidney disease. And I'll end up by discussing with you some possible pathogeneses by which Nafl might cause cardiovascular disease. So Nafl is a spectrum of fat-associated liver diseases. It begins with liver fat accumulation or steatosis, and in a percentage of patients, up to about 30% of patients, we think, simple steatosis might progress to non-alcoholic steatohepatitis with or without liver fibrosis. And this condition can progress on to cirrhosis and even hepatocellular carcinoma. And once cirrhosis and hepatocellular carcinoma is developed, specific treatments such as embolization may be required, or even liver transplantation to rescue the patient and save their life. So Nafl is a multi-system disease that has effects beyond the liver, and more recently we're appreciating through various different mechanisms, as shown here, that Nafl can increase risk of cardiovascular and indeed even cardiac disease, and Nafl can increase risk of type 2 diabetes, chronic kidney disease, and even certain cancers such as colorectal cancers and indeed other extrahepatic cancers. And I haven't got time to discuss this aspect of Nafl-associated risk, but I will touch on cardiovascular disease, type 2 diabetes, and chronic kidney disease. So work that we undertook with Giovanni Tarja in 2018, we showed in a meta-analysis then that Nafl was an independent risk factor for incident or new diabetes. And in reviewing the studies that were available at that time, we showed that the hazard ratio for incident diabetes, adjusting for all potential confounders, indicated that Nafl approximately doubled the risk of developing new diabetes. We updated that analysis in 2020, reviewing data from 33 studies of over 500,000 people, showing a very similar hazard ratio for incident diabetes. And indeed, there is a suggestion in this literature review that meta-analysis that Nafl increases risk of incident diabetes, perhaps even more so in those people that have more severe Nafl, defined by the development of liver fibrosis. Indeed, work that we'd done in 2016 in another meta-analysis, again with Giovanni Targia and colleagues in Verona, we showed that Nafl was an independent risk factor increasing risk of incident cardiovascular events, both fatal and non-fatal myocardial infarction and stroke, and that the odds ratio there for the increase in risk for incident cardiovascular disease was approximately a 60% increase. And indeed, in that analysis, there was a suggestion that when people develop more severe NAFL, again defined by liver fibrosis, that the development of liver fibrosis seemed to further increase risk of cardiovascular events. In work that I haven't got time to tell you about, we showed with Sarah Wild and colleagues in Edinburgh, in a cohort of patients specifically with type 2 diabetes using the Scottish Registry data, that even if one looks at the association between NAFL and incident cardiovascular events, specifically in a group of patients with type 2 diabetes, one can still see this effect of NAFL as an independent risk factor to increase incident cardiovascular events. And indeed, in patients with type 2 diabetes, the risk is very similar to the odds ratio that's shown on this slide, with an approximate 60% increase in risk of cardiovascular events. Work that we've done very recently, again with Giovanni Targia and colleagues, reviewing the literature of over 13 studies of over 1 million individuals developing incident chronic kidney disease defined by stage greater or equal to 3, as defined by the estimated glomerular filtration rate with or without accompanying overt proteinuria, followed for a median of almost 10 years of follow-up, that the summary hazard ratio from these studies indicates that, again, there's an approximate 40 to 50% increase in the risk of developing incident CKD with NAFL. So again, further evidence that NAFL is having an effect to increase risk of other diseases beyond the liver. Now, NAFL and type 2 diabetes represents a vicious spiral of worsening disease, and it's well known that type 2 diabetes increases risk of cardiovascular disease. This has been known about since probably the work of Stephen Hafner and colleagues back in the 1990s. But we now appreciate that if patients develop type 2 diabetes, this further increases the risk of severity of NAFL developing. So type 2 diabetes is a risk factor for the development of liver fibrosis. And work that I haven't got time to tell you about, NAFL increases risk of hepatocellular carcinoma and its advanced liver fibrosis developing with NAFL that massively increases that risk of increases that risk of hepatocellular carcinoma. So not only does NAFL increase risk of type 2 diabetes, which is a cardiovascular risk factor, but also increases risk of chronic kidney disease. But once type 2 diabetes develops, a vicious circle or a vicious spiral of worsening disease develops with a tendency towards more severe NAFL with liver fibrosis, and then NAFL further increasing risk of chronic kidney disease and cardiovascular disease, as I've shown you. Now, it's known that NAFL and type 2 diabetes are strongly associated with the various risk factors that form components of metabolic syndrome. And here are the Joint Society's criteria for defining metabolic syndrome from George Alberti and colleagues' work in 2009. And we know that with metabolic syndrome, there's an increase in fasting triglyceride associated with low levels of HDL. Here are the thresholds in men and in women as a criteria for defining metabolic syndrome. And this lipid abnormality of increased fasting triglyceride and low levels of HDL cholesterol with associated increases in small dense LDL cholesterol is known as the atherogenic dyslipidemia phenotype. And this atherogenic lipoprotein or dyslipidemia phenotype is well described in patients with type 2 diabetes and indeed with Nafl. And this is the specific lipid abnormality that we now know is associated with an increased risk of cardiovascular disease. Now, this is a very complicated slide, but the bit that I want you to focus on, that I'm going to discuss over the course of the next few minutes, is this increase in VLDL that is modified by these particular genotypes in Nafl, PNPLA3 and TM6SF2. And the excess lipid that accumulates in Nafl, one way of exporting that excess lipid is through VLDL assembly. And what one tends to see in patients with Nafl, or metabolic form of Nafl rather than the genotypic form of Nafl, is increased VLDL synthesis. And there's now increasing evidence that this VLDL synthesis, which is the increase in fasting triglycerides that I showed you on the previous slide, is a contributor to the increased cardiovascular risk. Now the question is that increase in VLDL specifically increasing cardiovascular risk in patients with Nafl? And we don't know that for certain, but there is some interesting data published in patients with obesity, and you'll be well aware that many patients with Nafl have obesity, showing that VLDL cholesterol in particular is associated with an increased risk of cardiovascular disease in patients with obesity. And these authors ask the question, does VLDL cholesterol explicitly explain a fraction of the excess risk of myocardial infarction in people with obesity? So these investigators from the Copenhagen General Population Study, investigating 29,000 adults at baseline, nested within a larger study of 109,000 individuals from that general population study with 10 years of follow-up data and 2,300 incident myocardial infarctions. They looked at the cholesterol content in large and small VLDLs, IDLs and LDLs measured by nuclear magnetic resonance spectroscopy. And in stratifying the analysis by whether subjects were obese, overweight or normal weight compared to underweight, these were their baseline triglyceride concentrations. And you can see in those that were obese, there was a modest increase in fasting triglycerides compared to those that were either overweight, normal weight or underweight. And this is the particular abnormality that we would see in patients with non-alcoholic fatty liver disease. Indeed, using NMR, they then measured the amount of cholesterol in large and small VLDL lipoproteins combined, and in the cholesterol content in large VLDL and small VLDL. And so on the x-axis here, I've shown the mediated excess risk in the association between BMI and risk of myocardial infarction. And what they concluded was that the cholesterol content in either large VLDL or small VLDL contributed to well over a third to 2/5 of the excess risk of myocardial infarction attributed to obesity. So here's very interesting data suggesting in those patients with obesity that do have increased fasting triglycerides, very typical of patients with NAFL, it's the cholesterol content in the VLDL molecule in particular that's accounting for a significant proportion of the excess risk of cardiovascular disease associated with obesity. And then if one moves back to asking the question, well, what's happening in NAFL, particularly in patients with NAFL, where we know that those patients who have either this particular genotype of PNPLA3 or this genotype of TM6SF2, which we know tends to be associated with lower levels of fasting triglyceride, lower levels of VLDL therefore, what happens then to risk of cardiovascular disease and risk of diabetes in patients with this genotype? Now, we don't know the answer to that specifically in patients who have NAFL, but looking to the UK Biobank population, these investigators looked at those patients in the normal population who now didn't have NAFL necessarily, but who had these genotypes that we know are associated with lower triglyceride, and asked the question, what happens to cardiovascular risk and risk of developing diabetes? And as you can see here, as expected, this was the decrease in triglyceride expressed as a beta coefficient in those patients with these particular genotypes. And indeed, as expected, there's an increased risk of fatty liver associated with this particular genotype. The reason this is negative is because these are the beta coefficients, and a negative beta coefficient on CT scanning represents attenuation of the liver signal or an increase in liver fat. So the genotypes, as expected in the general population, were associated with more liver fat, as we know from our studies in NAFL. But the same genotype then was associated with an increase in risk of type 2 diabetes, as we would expect. NAFL intends to increase risk of type 2 diabetes from the meta-analysis that I showed you earlier. If one looks to the effect on cardiovascular disease here expressed as coronary artery disease, it's very interesting to note then that in the general population, these triglyceride lowering alleles in the serum, lowering of VLDL, are associated with a decrease in risk of cardiovascular disease. So here we have first illustration of a genotype that we know in NAFL worsens severity of liver disease, as we would expect, increases risk of type 2 diabetes with that worsening of liver disease, but at the same time these two genotypes that lower VLDL decrease risk of cardiovascular disease. So here's quite powerful evidence there that it's this VLDL assembly that's modified by PNPLA3 and TM6SF2 that's modifying the atherogenic lipoprotein phenotype that has an effect, therefore, to influence the association between NAFL and in cardiovascular disease. The evidence being that where those patients with NAFL have this genotype, they tend to have lower levels of VLDL compared to other patients with metabolic NAFL. And it's that lowering of VLDL, we would suggest, via its effects here within the atherogenic lipoprotein phenotype, that's modifying or lowering its risk, the patient's risk of cardiovascular disease. So in conclusion, hopefully I've shown you that NAFL is a multi-system disease with implications beyond the liver. NAFL represents a wide spectrum of liver diseases that increases risk of type 2 diabetes, cardiovascular disease and CKD. The etiology of the increased risk of CVD is complex, but increased VLDL production in those patients that don't have that particular genotype but do have NAFL, perhaps via an increase in VLDL, and the effect on the atherogenic dyslipidemia, as I've shown you, is influencing the cardiovascular risk. And as I've shown you, the data is now suggesting that where you have that PNPLA3 genotype or the TM6SF2 genotype, that can modify the association between NAFL and cardiovascular disease, such that the genotype increases severity of liver disease and yet attenuates the risk of cardiovascular disease. And I've not had time to talk about it, but suffice it to say, therefore, we would argue that in all those patients with NAFL, it's crucially important to assess their cardiovascular risk to make treatment decisions about future risk management. Now, these are people I'd like to acknowledge who have hugely helped with this work, and I thank you very much for listening. And now I think it's...
Hi everyone, welcome to this EAS webinar. Today I will try to answer the question, is non-alcoholic fatty liver disease inevitably associated with cardiovascular disease? Lesson from human genetics. This is my conflict of interest and disclosure. This is the natural history of fatty liver disease. You see, when you accumulate fat, some individuals also get inflammation. And what it comes with a long-standing liver inflammation is production of collagen that results in cirrhosis and some individual also hepatocellular carcinoma. And these two are the worst condition as we have spoken. There are a number of common genetic variants that increase the risk of fatty liver disease. The color code here indicates those that increase. The blue represents those that are protective against fatty liver disease. And what happens is that when you are obese, there is an interaction with these variants and obesity by which in obese individuals, the size effects of this variant is larger. So the genetic background counts more in combination with environmental stressors. Today I will talk about TM6SF2, but before that, I would like to tell you about what is the homeostasis liver fat content. There are three things that regulates that. When we have an excess in caloric intake, we stimulate triglyceride synthesis mediated by the insulin signaling and SRBP1C. When we need to use the energy, the fatty acids are released from lipid droplets and they get utilized into the beta oxidation. When we have an excess of triglyceride, though, there's also another way for the liver to get rid of triglycerides, and the liver does it, the hepatocyte does it by secreting apolipoproteins containing a high content of triglyceride that in the fasting conditions you will see are the fasting triglycerides. So this is the pathway that I will talk about today. Lipid droplets, where you store fat when it's needed or when it has to be secreted. Lipases release fatty acid that then get re-esterified into triglycerides in the ER. And then we have this enzyme MTTP that constitutes of two subunits. One produces the apolipoprotein B protein, and the other subunit enriches the protein of triglycerides, forming the nascent VLDL. Remember that each of these particles has only one apolipoprotein B, but the nascent VLDL needs to be further lipidated before getting out into the bloodstream, and this happens probably in the Golgi. And in 2014, Helen Hobbs' group showed by doing an X-Y association study a genetic variant in the TM6SF2 that was associated with high liver fat content. They also showed that the sequence variant was a loss of function and that the wild-type protein was a transmembrane domain present in the Golgi that was responsible for the increased lipidation of the VLDL. They used a mouse model, and in this mouse model, this was the only activity of the protein, no effect on the number of apolipoproteins secreted, but only the amount of fat incorporated in that. So quality and not quantity of ApoB. So we wanted to test that the genetic variant E167K was associated not only with increasing liver fat, but also increasing liver fibrosis. And so we examined a cohort of individuals from Northern and Southern Europe in which we had available DNA and liver biopsy. And this is what we found. Carriers of the variant had a high risk of having non-alcoholic steatohepatitis or NASH, but they also had a higher risk to have advanced fibrosis. But surprisingly, when we look at carotid plaques, we saw that there was actually a reduction in that, indicating possibly less atherosclerosis. So to test the hypothesis that carrier of the variants were protected by atherosclerosis, we look at 2,000 individuals from the Swedish obese subject study, in which we had about 15 years follow-up and also the recording of all the myocardial infarction and cardiovascular disease. And you can clearly see here that carriers of the genetic variant had lower risk of cardiovascular disease. This hazard ratio was maintained even when we adjusted for all the traditional risk factors for atherosclerosis, except for when we included in the model total cholesterol, indicating that the effect was mediated by that. So when we look at the lipid profile, we saw that consistently was shown carriers of the mutation had less circulating triglyceride, but surprisingly, we also found less ApoB. As I told you, there is only one ApoB for each of the VLDL particles secreted. So we thought that here there is something more than changing only the lipidation of the protein. It must be also the quantity that is low. So we tested this hypothesis. We couldn't do it in mice because the mouse did not show any difference. So we did it in a 3D human model consisting of spheroids. And this is how we generated spheroids. After a week in this wells, round shaped, you see slowly there is a circle, a ball that is formed, a sphere that is formed when you use primary hepatocytes. We use primary hepatocytes from donors carrying the wild type or the mutant TM6SF2 protein, and we also use different fatty acid exposure to mimic in a way the gene environment interaction. These are beautiful pictures, and the orange dot represents the amount of neutral lipids in the spheroid, and you can clearly see that in both low and high fatty acid, carrier of the spheroid from donor carrying the TM6SF2 mutant protein had more fat than non-carriers. So next thing, we look at ApoB in the media of these spheroids, and we found a profound reduction in the levels of ApoB in the media of spheroids carrying the mutant protein. So we next went and looked at the lysate, and we also found a reduction in the protein levels within the spheroid. So we also look at mRNA levels of ApoB, and there was no difference between wild type and mutant, indicating that if anything, TM6SF2 is also involved somehow in ApoB protein stability after the translation of the protein. So we showed that TM6SF2 was involved not only in the quality of the lipoprotein secreted, but also on the quantity, so the number of apolipoprotein B. And this is the model. So carriers of this mutation have higher liver fat and lower secretion of lipoprotein, and therefore they are protected by cardiovascular against cardiovascular disease. So if you look at rare variants, I'm not going to go into details, but we also found that in individuals with hepatocellular carcinoma on NAFLD, there is a large excess of individuals with mutations in ApoB that cause higher liver fat, consistent with the data we found in TM6SF2. It's the same pathway. So the take-home message is that hepatic ApoB retention results in chronic liver disease, and that individuals with low circulating lipoproteins are protected by cardiovascular disease and may be at risk for fatty liver disease, because low triglycerides and cholesterol is not only due to mutations reducing ApoB retention, but also there are other causes of that. It's not necessary that, but it's an indication that it may be due to that. I would like to acknowledge my funding agents, my group in Gothenburg, Sweden, and I would like to say thanks to all my collaborators around the world, especially Luca Valenti from Università degli Studi di Milano in Italy. Thank you.
Good afternoon. Thanks again for the invitation. I'm Luca Valenti from the University of Milan. The topic of my presentation will be the old and emerging therapies for non-alcoholic fatty liver disease. These are my disclosures. So as you know, non-alcoholic fatty liver disease is now the leading cause of liver damage worldwide, affecting about 1/3 of the general population, in particular those with this metabolism, with genetic risk factors, and in particular those with concomitant or risk alcohol intake, which was one of the reasons why recently it has been proposed to redefine this condition as metabolic dysfunction associated fatty liver disease, or NAFLD, highlighting the contribution of metabolic risk factor and possible the synergies with excessive alcohol intake in determining progressive liver disease. From a pathological point of view, this is a heterogeneous condition ranging from simple uncomplicated steatosis, which rarely progresses towards a severe liver disease, to non-alcoholic steatohepatitis, or NASH, characterized by hepatocellular ballooning, inflammation, and activation of fibrogenic, which can lead to cirrhosis, its complication, and primary liver cancer. And we know that the stage of liver fibrosis, from mild periveneal or periportal fibrosis toward bridging fibrosis and cirrhosis, and main prognostic determinants of the risk of liver-related events, and also for overall mortality in patients with NAFLD, therefore represents the leading therapeutic outcome for this condition. So what are the therapies available to manage this condition? Up to 2020, the main managements for approaches for this condition were based on the modification of lifestyle factors predisposing to this condition, in particular weight loss, aiming to achieve a 5 to 10% body weight, which may be achieved also by bariatric surgery associated with physical exercise, whereas no drugs were approved or indicated for this condition, except for a few data suggesting that in diabetic patients, vitamin E supplementation may reduce steatosis and inflammation, whereas pioglitazone in patients with diabetes may improve liver damage and in long-term liver fibrosis. But as I said, there was no specific drug approved for this indication. So what are the bases for this recommendation? The main one is that the degree of weight loss correlates very well with the metabolic improvement in patients with NAFLD, and the degree of improvement also in liver damage that can be obtained by this approach. For example, and there's a large studies which was conducted in Cuba and other approaches based on lifestyle was demonstrated that the degree of weight loss correlates with the histological improvement, which can achieve the resolution of non-alcoholic steatohepatitis and the risk of progression, and for weight loss higher than 10%, also the progression of liver fibrosis. But only a minority of patients is able to achieve this goal, in particular significant weight loss able to improve liver fibrosis, and of this patient, less than 10% is able to sustain this weight loss at 1 year. So therefore, pharmacological approaches are clearly needed to improve the ability to achieve resolution of progressive liver damage, NASH, and the progression toward more advanced liver disease. This weight loss for individuals with severe obesity can be also achieved by bariatric surgery. This is highly effective in determining resolution of liver damage in the majority of patients. In the study that evaluated the evolution of liver damage in patients with NASH at baseline who underwent metabolic bariatric surgery, it was shown, for example, that by systematic reevaluation of liver biopsy, the severity of liver damage improved in the majority of patients at 5 years, with most of them achieving complete resolution of liver fibrosis. But should be noted that a significant proportion was still affected by severe fibrosis F3 and F4, thereby being at high risk, persistently high risk of developing liver-related complications. Besides, however, the amount of deposited insulin resistance dietary factors directly play a role in determining increased risk of this condition. This should be possibly modified in order to decrease the risk of progression. The main one is the dietary intake of fructose, which is directly correlated, in particular industrial fructose, with the risk of hepatic fat accumulation, liver damage, and progression towards a severe liver disease. But also the overall pattern of the diet may be important, as there are data suggesting that a Mediterranean pattern of diet is superior to an isocaloric dietary approach, for example, based on a low-fat diet, in determining improvement of some insulin-resistant features, but in particular in determining a more marked decrease in hepatic fat accumulation and in biomarkers of liver damage. So therefore, the current approach to the management of this condition should be based on the multidisciplinary management by the specialists, including the hepatologists, but also a multidisciplinary team with endocrinologists to manage the metabolic complication, nutritionists, psychologists, possibly integrative weight loss centers, and by specialists who also take care of the management of cardiovascular risk factors. As you know, and we have heard from the previous presentation that cardiovascular events represent the main cause of severe clinical events, and this patient treatment of comorbid condition and prevention strategy is in those with advanced liver disease. Clearly, we need drugs to improve our ability to stop the progression of this disease. There are several approaches which are under evaluation and at different stages of clinical studies, which are based on different approaches targeting the different steps in the pathogenesis, from metabolic derangement to inflammation, fibrogenesis, and the complication of liver disease. But which are the main patients that have to be targeted by this condition? Clearly, the therapies that should be aimed to improve liver-related outcomes should be mainly directed to patients with NASH, the progressive form of the condition, or with clinical significant liver fibrosis stage F2, F3, and in those with cirrhosis. But this is a particular subset of patients because some of the drugs may be counterindicated due to hepatic dysfunction. And the main outcomes that the hepatologists want to achieve are the improvement of liver fibrosis, because this is the main prognostic determinant, but also the resolution of NASH, or nonalcoholic steatohepatitis, the activity of the disease without worsening of fibrosis. an important concept I want to stress in particular in the setting that the most important outcome is the overall impact on clinical events, which should balance the impact on liver-related events and of cardiovascular events, which are still the main cause of mortality and also a clinically significant event in patients with this condition. So, by this approach, we seen that a number of treatments targeting oxidative stress, such as vitamin E, insulin resistance, such as pioglitazone, and other drugs targeting lipid metabolism were effective in reducing liver fibrosis. And these were, in particular, the same treatment that show a significant impact in reducing the hepatic fat accumulation in patients with NASH, highlighting the fact that modulation of the hepatic fat accumulation and probably the gut-liver axis, because the intestinal microbiota plays here a very important role in modulating the profile of bile acids, which are agonists of FXR, that is involved in the regulation of liver damage and this condition. And obeticholic acid, we have seen it is a prototype of FXR agonist that may show an activity towards a reduction of liver damage in these patients, steatosis and fibrogenesis. So on the other hand, the anti-inflammatory drugs and those targeting directly fibrogenesis didn't show a significant impact on the progression of liver damage. So therefore, among the first drugs that reached phase 3 trials, only obeticholic acid, FXR agonist, were demonstrated to significantly improve the rate of fibrosis progression and induced regression of fibrosis and clinical events. In particular, this was shown in the study published in 2019, showing encouraging results, in particular for the 25 milligram dose, which however was associated not only with pruritus in a subset of patients, but also with development of hypercholesterolemia, which, as you know, may be particularly harmful in patients with this condition due to the very high baseline risk of cardiovascular disease. But luckily enough, it was shown to be manageable by the co-administration of statin or the increasing the dose of statins used to treat this condition, and thereby reducing the liver damage. And we know that statins are very important because they can directly inhibit lipogenesis, inflammation, and probably fibrogenesis in patients with NASH. And we also have some initial data linking genetic variants reported in the previous presentation with a differential response to statin treatment, which would be more effective in those not carrying the genetic risk variants associated with altered remodulation of hepatic lipids, but very effective probably in preventing liver damage progression in those with pure metabolic NAFLD and low genetic contribution for this condition. So, gut-liver axis, however, remain a viable target. We've seen that FXR agonists are a very promising approach. The prototype is obeticholic acid. By the FXR effect is probably partly mediated by secretion of FGF19 and enterokine, which is able to induce bile acid detoxification, reduce steatosis and inflammation in the liver. And we have already data showing that partial FGF19 agonists are able to induce a marked decrease in liver fat in patients with NASH and of biomarkers and improving histological outcomes. Other pathways leading to reduced accumulation of fat in the liver will probably also be important. We have data showing that liraglutide is able to reduce hepatic fat accumulation, inflammation, probably due to facilitation of weight loss, due to the central effect on appetite. And there are recent data demonstrated that semaglutide, in particular at a higher dose of 0.4 milligrams, was able to increase the rate of NASH resolution in patients with NASH as compared to placebo. And again, here the effect was mainly mediated by the ability of this GLP-1 receptor agonist to promote weight loss in patients with NAFL, resulting at the same time in a concomitant improvement in the metabolic profile and biomarkers of liver disease. What's in the future, probably combined PPR gamma, alpha and delta agonists will also be able to improve liver damage with a more favorable side effect profile as compared to pure PPR gamma agonism, and possibly other drugs modulating hepatic lipid metabolism, and in particular beta oxidation, such as thyroid receptor hormone beta agonists, will also be evaluated due to their ability to induce a marked decrease in hepatic fat content and biomarkers of liver damage, as recently shown for resmetirom. Direct inhibitor of lipogenesis also under study. One of the targets still coenzyme A carboxylase, which is involved in regulation of lipogenesis, the synthesis of lipotoxic mediators, and also in relieving a break to the lipolysis, although this results in hypertriglyceridemia. But a final note should be left to highlight the importance of the management strategies to treat type 2 diabetes in individuals with NASH. Indeed, different new drugs may have a differential effect on hepatic fat accumulation. For example, in this recent study, which considered patients who were shifted from metformin treatment coupled with sulfonylureas and glitazone to new treatments strategies, including the DPP-4 inhibitors, GLP-1 receptor agonists, and inhibitors of SGLT2, it was shown that the administration of GLP-1 receptor antagonists and glyphosate were associated with a more marked increase and a decrease in adiposity, amelioration of diabetes, and this resulted in an improved amelioration of markers of liver injury, including ALT, indices of hepatic fat accumulation, and also fibrosis. So also, we need more data to strengthen this data. It is likely that in patients with type 2 diabetes, higher risk of progression, some therapeutic approach may be more advantageous for preventing liver disease than another, and should be favored in the future. So in conclusion, for the treatment of NAFLD, the backbone of treatment, including in patients with simple overweight or so-called normal BMI, should remain weight loss. This should be achieved by lifestyle modification, anti-obesity drugs, including GLP-1 receptor agonists in particular, and surgical approaches. This should be coupled with control of this metabolism, in particular hypertension. There are, for example, data that EAS inhibitors may protect from fibrogenesis, dyslipidemia, because statins may also have direct effect in the prevention of liver damage, the optimal management of hyperglycemia, including preferential use of glitazone, but also GLP-1 receptor agonist, probably metformin because it has anti-carcinogenic activity. And in the future, probably we will have drugs directly targeting liver damage in these individuals. Thank you for your attention. So, key messages: NAFLD is projected to become the leading cause of end-stage liver disease and liver cancer by 2025. Lifestyle changes and multidisciplinary approach to treat the metabolic comorbidities are the cornerstone of treatment. Weight loss by lifestyle change is the key, and the modulation of hepatic lipid metabolism and the gut liver biopsy are providing promising results. Thank you.
No, thank you very much to all the speakers for their excellent talks. And there has been going on a lot of questions during the time of the talks here in the chat room. Do you hear me, your speakers?
Yes.
Stefano?
Yeah.
Yes.
Yeah. Everyone hears you very well. Yeah, it was a bit hard keeping up with the talks and also answering the questions on the chat.
Maybe we can come back to some of the questions now.
Yeah, I wanted to answer this. Yeah.
Okay, Stefano,
go ahead.
Go on.
Yeah. This last question that I read: what statin would you use in NAFL NASH? And I believe atorvastatin would be the best because it's the more lipophilic and therefore gets more in the liver. So I would expect to have a higher effect than rosuvastatin. This is my feeling, but it's only my thoughts.
Yeah, I'd agree with that, Stefano. Sorry. Yeah, I'd agree with that, Stefano. I mean, I think that, one of the things that I'm quite interested in with respect to atorvastatin is, of all of the statins, it seems to have more of a potent effect on VLDL. So, particularly at high dose, high dose atorvastatin is certainly more effective at lowering triglycerides.
Yeah. So clinically, you also see a reduction in ALT after you start them on a statin. So, although it's funny that in FH patients, it actually increases ALT. So those that are very lean have a mild increase in ALT. Those with NAFL, it actually reduces. So I still don't understand what's the deal there. But certainly is not bad for the liver.
Yeah, I also agree. I mean, we clearly need more data, but there is clearly some
somebody has
preliminary data support on this.
No?
Somebody has a question about ezetimibe as a cholesterol absorption inhibitor in the gut.
It's a very good question.
And it's a very good question. And I think the honest answer is at the moment that giving ezetimibe as an inhibitor of cholesterol absorption probably doesn't affect liver lipid. I mean, there's a little bit of data that's not very good data to suggest that it might have a benefit. But I have to say that I've not been particularly convinced. That there aren't really any that I'm aware of convincing high-quality biopsy study data. I think there's a little bit of evidence from a small biopsy study data. I'm forgetting the name of the study at the moment, but I've not been very convinced by the effect. I think just following on from that, what's particularly important with respect to obeticholic acid treatment that's having a lot of exposure at the moment for those of us working in the field of NAFL research and is potentially useful for NASH and maybe also for fibrosis and is gaining a lot of interest and a lot of push from the drug company. That one of the worrying things about obeticholic acid as an FXR agonist is that it does cause a very marked increase in LDL cholesterol. And although that LDL cholesterol is lowered by statin treatment, what we do know about statin treatment and high LDL cholesterol is that statins don't completely abolish all of the increased cardiovascular risk. So personally, I would have some concerns at the moment about obeticholic acid and its effects on the cardiovascular system.
Yeah, I completely agree with you. I mean, currently the FXR agonists are the class of drugs that provided the most promising results on the amelioration of fibrosis. But clearly, besides the impact on pruritus, there's increase in LDL cholesterol and the need to increase statins with also the possible impact on type 2 diabetes is very concerning. So for this reason, I wanted to stress that we need to see the overall impact on clinical outcomes, including cardiovascular events in this patient before drawing conclusions. Absolutely.
There's an important question about NAFL as a common complication in patients with dystrophy.
Yeah.
And yes, this is exactly a group of patients with lipodystrophy, either genetic lipodystrophy or acquired lipodystrophy, that really do run into problems with Nafl, NASH, liver fibrosis. And Henry Ginsberg had a question earlier that I addressed. And it's really adipose tissue dysfunction that's probably very important in the pathogenesis of NAFL. And the patients with lipodystrophy have got very abnormal very abnormal adipose tissue function. So these patients are at risk of NAFL, and there is some evidence in some patients with lipodystrophy that they might respond to pioglitazone. And pioglitazone is a forgotten cardiovascular protective agent that we've known about as diabetologists for the last 20 years and used very effectively in diabetes circles, that's really fallen out of favor because of a few of its side effects. But pioglitazone at least has some benefit in many patients with NASH to affect the liver. It attenuates risk of diabetes and lowers blood glucose in patients with diabetes. And it certainly in patients reduces cardiovascular risk, so risk of myocardial infarction and stroke. So I think in patients where you have acquired lipodystrophy or a genetic lipodystrophy who are at risk of NAFL, it is worthwhile considering pioglitazone treatment.
Okay, there's been several questions on the role of inflammation in cardiovascular disease. Does anybody have a comment on that? The role of induction of inflammation in the AFLD patients?
My personal
Please do have a comment.
My personal view is the inflammation is secondary to the lipid-mediated effects.
I also believe that the risk is mediated by lipoproteins. There is no X factor like, CRP or whatever you want to think that goes from the liver to the heart. I really believe is mediated by the lipoproteins and also the risk of diabetes. That is also a risk factor for cardiovascular disease. This is the way I see it, but I think we all see the three of us see it the same way. I'm not sure, Luca, what you think. I agree with Chris.
Yeah, me too. I mean, there is no indication that some inflammatory mediators may be involved besides the impact on lipoproteins insulin resistant. There are some data on PCSK9, but I mean, there is no proof that it is a mediator of the association.
So somebody's raised a very important question about should we test our patients for PNPLA3? I mean, I'd be interested, Stefano, as you're the expert on types.
I would be having Luca to answer that. I feel a bit biased on that.
Yeah, I'm also very biased. I mean, this may represent a strategy to select those patients at higher risk of liver-related as compared to cardiovascular complication of this condition. But it's too early to recommend it in clinical practice, but very promising.
Someone asked the question about HDL particles and are they functionally relevant in NAFL? And I think that our view about HDL and cardiovascular protection has probably changed over the years, and it's the functioning of the HDL particle that's particularly important rather than its absolute cholesterol content. And we've known from the CETP inhibitor trials in cardiovascular risk reduction that just increasing the cholesterol content of HDL particles probably does not affect cardiovascular risk. So it's all about functioning of the HDL particle. And there are not very many studies that have really addressed that in patients with NAFL that I'm aware of.
I wanted to just comment on Henry Ginsberg comments on the specific. I don't want to be reductive saying that it's all about lipoproteins. And I agree with you that there may be some specific lipids in the lipoprotein that may be more toxic, although nothing has been shown yet on that. So I really believe also in quality rather than quantity. Absolutely.
There has been, during the lectures, a couple of questions on fatty acid in the nutrition, that both omega-3 and polyunsaturated fatty acid. Some more comments on that?
Yeah, so we in 2014 undertook a randomized double-blind placebo-controlled trial testing the effects of high-dose Omacor. And Omacor contains eikosapentaenoic acids, so 20 carbon atoms long as an omega-3 fatty acids and 5 double bonds, combined with docosahexaenoic acid, which is 22 carbon atoms long and 6 double bonds as an omega-3 fatty acid. And at the same time that we published that MR-based study in hepatology in 2014, the NASH CRN reported at exactly the same time the results of the NASH CRN study, where they tested high-dose eikosapentaenoic acid only in a biopsy study in patients with NASH. Now, they failed to show any effect of EPA on the liver in NASH. And we also, as in terms of our primary endpoint, which was changing liver fat by MRS, we too failed to show that any effect of the Omacor, the combined preparation of DHA and EPA, we failed to show a benefit on liver fat. However, in a post hoc subgroup analysis where we tested the individual effects of EPA, so we measured incorporation of EPA into red blood cells, into the phospholipid membrane in the red blood cells. We tested enrichment of EPA and tested enrichment of DHA in those red blood cell phospholipids. And to our surprise, we showed a very strong and independent association between the decrease in liver fat, triglyceride measured by MRS, and the enrichment of DHA. And that was that enrichment of DHA with treatment, strongly and independently associated with the decrease in liver fat. So I'm still uncertain as to whether all omega-3 fatty acids are the same and whether there are differential effects of individual omega-3 fatty acids on the liver and maybe on the cardiovascular system.
Chris, remind me, in the study, the average fat of the cohort was not very high.
No, it was. These were patients, Stefano, in our study that were recruited from secondary care hepatology and liver clinics, and the baseline MRS liver fat percentage was 28%.
No, okay, so it was very high.
Yes. Yeah, so this was a decent amount of liver fat.
Yeah, and, absolutely.
And there was a substantial reduction and a significant reduction that was independently associated with DHA enrichment.
Yeah.
Okay, thank you. I think it's time to close, even if the interesting discussion going on. I would like to thank on the behalf of EAS for the speakers. Thank you very much for excellent talks. And the presentations will be available on the EAS Academy within a few days for those who want to go back and have a look at them there. So thanks again, and good luck.
Thank you very much.
Research.
Thank you very much
for being with us. Thank you, guys.
Thanks.
Bye.
Bye. See you.